or the top of the hour, 2 o'clock Eastern Time, according to my computer, so we're going to get started here. Good afternoon. Welcome to today's webinar, Burns Medico-Legal Considerations. During this webinar, our presenter will cover essential concepts in understanding burn injuries. Classifications, types, mechanisms, and treatment modalities will be clearly discussed to familiarize the participants with the current thoughts in this field. Medico-legal implications pertinent to the plaintiff and defense aspect of burn injury litigation will be discussed with a number of case examples. Our presenter for today's webinar is Dr. Michel Brones. Dr. Brones is a board-certified plastic and reconstructive surgeon. Dr. Brones is currently in private practice after 17 years of experience as a plastic and reconstructive burn surgeon at the Grossman Burn Center at Sherman Oaks Hospital in Sherman Oaks, California. Dr. Brones specializes in all areas of plastic and reconstructive surgery with a special emphasis on burn injuries, hand surgery, and cosmetic and reconstructive procedures. Dr. Brones has more than 25 years of experience testifying for plaintiff and defense cases involving personal injury, product liability, medical malpractice, civil and criminal cases. Dr. Brones would like this presentation to be as interactive as possible. He has asked that we do not take any question and answer breaks, but that we field questions on the fly, as it were. So please use the chat feature or the question and answer feature, which is found on the right-hand side of the screen, to submit your questions at any time during the presentation, and Dr. Brones will do his best to answer your questions. Approximately 1 hour after the conclusion of the event, we'll send out an email with a link to the archived recording of the webinar, along with a copy of the PowerPoint presentation that was used during the webinar. We do ask that you take time to fill out the survey that will appear on your screen after the webinar is over. I now invite you to sit back, relax, and enjoy the presentation. I'm now going to turn it over to our distinguished speaker, Dr. Brones. Dr. Brones, it's all yours.
Thank you so much, Matt, for that wonderful presentation, and thank you, everybody, for attending this seminar. Like Matt said, what I'd like to do is to make this as interactive as possible for everybody. Number one, it makes it much more interesting for me, and I'm sure that it makes it much more interesting for you as the attendees to this meeting. I imagine that the reason that you're all here, besides wanting to hear my lovely voice, is because you have a case that is either pending or about to be filed, or that you're thinking about filing, or that you're thinking about defending. So I'm sure that there are some pertinent questions in everybody's minds, and I would like to be able to answer those questions as we go along in the presentations. A great deal of my work nowadays is related to medical legal issues. I work about 50% of my cases for defense and about 50% of my cases for plaintiff firms. So I'm pretty much in the middle of the litigation field, as it were, and I'm pretty much aware of the concerns of either side with these type of injuries. Enough of the introduction, and let's go into the presentation per se. I'm going to go through a few of the slides, and what I'd like to do is go first through the medical aspect. I'll try to make it as interesting as possible and as entertaining without being too boring, but a few of the medical aspects you'll have to bear with me, because those are very important in determining later on the legal aspects and the ramification. Okay, basically burn injuries are different from any other type of injury. Most of the injuries we think about are internal injuries, injuries that once they are healed do not leave an external scar. Burns are the full opposite of that. These are injuries that are visible from the beginning through the procedures of hospitalization and healing, and certainly in the cases in which we're all concerned, burns do leave residual scarring, which in the case of burns affecting the face or the hands or areas of the bodies that are exposed will be scarring that will be, of course, observable to everyone. And as such, it represents a tremendous not only physical, but emotional and psychological impact. Besides that, burns are related atavistically and historically to fears and frights and nightmares. So as such, they represent a particular field of medicine that is a little bit different from regular medicine, if we may call it such. Let's start with how do we classify a burn? Nowadays, every burn that enters a burn center, the first thing that is done is to analyze what is the total body surface area burn. I'm going to quickly go to the next slide so we'll understand what that is. Hopefully you can read the slide, but as you can see in this slide, there are percentages that are given to each part of the body, and you can see, for instance, that the anterior arm is 4.5, meaning that the entire extremity, front and back, is 9%. Similarly, if you look at the lower extremity, you would see that the anterior aspect is 9%, the posterior aspect is also 9%, which means that the entire lower extremity is 18%. Then you have the anterior trunk, which is the chest and abdomen. That would be 18%. The full back will also be 18%. The face is 4.5, and the back is 4.5. So, for instance, that would quickly allow you to estimate what is the percentage burn. If you have a patient that presents, let's say, to you to analyze with a burn of the face, you would know that the burn is approximately 4.5% total body surface area burn. That is very, very important because, and I'm going to go back to the prior slide now, that is very important because that will determine the morbidity and, most importantly, what is the chances of that burn being a fatal burn. Obviously, the greater the percentage, the greater the chance of a burn being lethal. And nowadays, even with all the advances that we have in the medical field, some of these burns do not survive their injury. So it's important for us to determine what is the total body surface area burn, and in order also to analyze what is the treatment that is given in different places and what is the difference in approach and in treatment. So that is a very, very important concept, and the rule of nines is what we've just gone through. Now, let's talk a little bit about what are the burn unit admission guidelines, and we're going to go again to the slide that we just saw. And as you can see there to the left, the admission guidelines, and these are guidelines that are given by the American Burn Association. And it is important to understand these guidelines in analyzing from a legal point of view as to what was the appropriateness of the treatment that was given to that particular individual. Was the individual treated appropriately, and was the individual treated where he should have been treated? So, for instance, you see that partial thickness burns, and we will explain what is a partial thickness burn, greater than 10% total body surface area burn in patients of all ages. It is recommended that they seek at least a burn center consultation. The reality is, though, that many burns that are greater than 10% are treated in institutions that do not qualify as burn centers, and still the standard of care is acceptable. The second consideration for admission, and that is more of a stricter consideration, would be any type of burn that involves the face, the hands, the feet, the genitalia, the perineum, or major joint areas. The reason for that is because burns have a tendency to heal by contracting, so any burn that affects a major joint area has to be appropriately treated. Otherwise, the way that the burn will heal will limit the range of motion. The joint may be contracted, and that is one of the reasons that burn center admission and treatment is recommended. Any third-degree burn of any significance, and we'll explain later on what is a third-degree burn and what is a partial thickness burn. Certainly, any type of electrical injuries. Electrical injuries, we'll explain a little bit later on how we divide them, but lightning is included in electrical injuries. Believe it or not, some people do survive a direct lightning bolt exposure, and of course they have to be admitted to a burn center. The next topic is chemical injuries. For those of you that have had to either defend or that you have clients that have been involved with chemical injuries, they occur most commonly in a working setting. Not always. It could happen in a pharmaceutical setting. It could happen, of course, in a chemical lab. It could happen certainly in a hospital setting, is very commonly. It could happen at home, but the most commonly related to work injuries. And we'll discuss a little bit later on what is the difference between an acid burn and an alkali burn, and what is the treatment that is associated with that. Then we have inhalation injuries. Any patient that has suffered any significant inhalation injury should certainly be admitted and or evaluated in a burn center. And the last point is circumferential limb or chest burns. The reason why a circumferential burn needs to be evaluated and or admitted at a burn center is because if you could imagine a burn, particularly a third-degree burn, and we'll explain a little bit later on what that is, will heal by contracting, and there will be a tourniquet-like effect. So if you have a tourniquet-like effect in the upper extremity or the lower extremity, there will be vascular compromise. Consequently, the vascularity has to be very, very clearly monitored, and a procedure called an sclerotomy, in which we basically cut through the burn, may need to be acutely and promptly performed. So these are kind of basically the basic guidelines. I just want you please to be aware that these are not set in stone. So if you have any clients or patients that were treated outside the burn center, and even though they met these criteria, do not assume that those cases were inappropriately treated. Some of these cases, if they are minor in nature, they're still treated at regular hospitals. But I just want you to have a general idea. At the lower left corner, I hope that you can read, it's a little bit small, but it's basically we're talking about the fluid resuscitation guidelines for a burn injury. The first thing that happens after somebody is burned, and we're talking about a burn of any magnitude, meaning 15-20% total body surface area burn or greater, the first thing that will happen is that the patient will become immediately dehydrated. You lose great amount of fluid, great amount of volume. And before anybody understood really about this, the number one reason why burns would die and would not survive is because they went into shock due to the great loss of fluid. They do not lose blood, but they lose fluid, and consequently they become hypotensive and they died. So what we do now, the first thing that is done at any hospital is to insert an IV and give the patient a great amount of fluids. The fluid guidelines is what is said there. It's kind of a little bit difficult for you to read, but basically we have a formula that we use that can be tweaked a little bit, and we base that according to the urinary output of the patient, how much urine the patient is putting. And that is the reason why you would commonly see a patient that is in the burn center that is massively swollen, and the reason for that is because great amount of fluid is being given to the patient to combat that dehydration. The number one reason why patients die nowadays is infection. Almost rarely we would have a patient dying from dehydration, but what patients do succumb to is infection. That we're still having problems with. So this is basically just an overview of a little bit of the burns. I'd like to go a little bit more specific now, and let's go to the next area that would probably be an area a little bit more of interest to you from your point of view. This is what I see every day in my practice, and this is what commonly brings cases to the table. I would say that the number one type of injuries that I see are related to hot water burns. Scalp burns, tap water scalds, immersion burns, and of course, children and elder abuse case. These are the most common type of injuries, either related to the most mundane type of cases like hot coffee burns, hot tea burns, hot soup burns at Chinese restaurants, hot coffee burns at, we've all heard about McDonald's cases, all of those, and then the tap water scalds related to hot showers, and that is the reason why many apartments get sued because of the hot showers or a hot tub. The immersion burns, that could be related either to, again, somebody being burned because the water is hot, and of course, children and elder abuse case related to this type of injuries with a hot shower, with a hot tub, and I'll go a little bit more in detail when we talk about individual cases. But I wanted to show you a very interesting chart, which is the chart that follows. And I hope that is clear to everyone that looks at this chart. This is the type of charts that we present all the time when we go to court, and the type of charts that we use in order to explain to the jury what happens in a burn and how does a burn occur. There are basically two elements in a burn, and that is duration of exposure to the burn, to the burning agent, and two, obviously, the temperature of the burning agent. Once you know those two elements, then you can pretty much tell whether the burn is has occurred according to the story that was given or not. If you look at the picture, you can see that at about 120 degrees Fahrenheit, which is, by the way, the recommended water heater setting, that is what comes from factory. The thermostat is set at 120 degrees. And you can see that even at the recommended water heater setting of 120 degrees, you could have a serious burn injury in 5 minutes. You can see that at 155 degrees, which is the top one, you could have a serious burn injury in 1 second. So basically, all the recommendations from all the manufacturers are to set your water heater no higher than 120 degrees, so 48 degrees centigrade. This becomes quite important in all the cases that are associated with basically hot shower burns, hot tub burns, and the allegations that the water heaters were either incorrectly set, or that they were set too high, or that there were no anti-scalding devices, or that somehow the typical case is the one that says that they were running the toilet, and consequently the water in the shower became hot and the patient got burned. Or that something else happened, there was a diversionary output of cold water, the water became too hot, and the patient sustained the burn. So when you look at these type of allegations from my point of view, from an expert point of view, I always want to know what is the duration of the exposure that was the allegation, and what was the temperature of the water that was the agent that produced the injury. and there was a question, and I'm going to briefly touch about this question. One of the attendees wanted to know whether an expert could make a differentiation between an immersion type of injury and an injury that occurs secondary to steam from a boiling pot. The answer, yes, we can make that very clearly, because in an immersion burn, if you can imagine the patient, let's say typically in a hot tub, in an immersion burn, you will commonly see what we call a demarcation line, which is basically there is a line that is very sharp that is dividing the part of the body that of course was immersed, submerged into the water and in which the injury occurred, and the area above that in which there is no injury. And there's usually a sharp line that will demarcate that. That is only one of the elements that we see. The other element that we looked at is at the uniformity of the burn injury. If the burn injury is uniform in nature, if the burn injury has a demarcation line, and of course if the burn injury is in the areas that were allegedly submerged, then most likely than not you're dealing with an immersion type of burn, especially if the patient was also a young child or a elderly patient. A steam type of burn does not have any of those characteristics. It is irregular in nature. It is not uniform in nature. There is no demarcation line, and usually is not as deep. So that would answer, in my mind, at least the basic answers as to what would be the difference between immersion burn and a steam burn. And also the question arose as to whether you could have either an immersion burn or a steam burn to your face and heal without scarring. The answer is yes, depending upon the degree of burn, whether it's first, second, or third, and we'll discuss those briefly later on. You could have a burn that will heal without any scarring. The elements that would be important there would be first and foremost who the patient is, because certainly a patient that has a tendency to keloid or to scar badly will have a tendency to have worse type of scarring. And a patient that has a tendency to heal better may not have any scarring, even though there was indeed an immersion type of burn. So those are all elements that are important in assessing a case. And please do not take any of the things that I said at a total face value. Everything has to be evaluated in the entire context of the case before a full determination can be made. But just going back to this chart that we're looking at, as you can see, infants and children, older adults, and people with disabilities are particularly susceptible to this type of injuries and to this type of claims. I've had many a claim dealing with people with disabilities that are in either nursing homes or in facilities that are taking care of them, and injuries occur related to burns. Injuries occur that are related to burns. One second, I'm sorry that there is a telephone ringing in the background. It'll stop probably pretty soon. I'm sorry. And injuries, one minute. I'm going to have to put you on hold. Just 1 second, please.
You want to look at some drivers, too? Yeah.
Okay, I'm back on the conversation. I apologize. And injuries do occur in those settings that end up being litigated because, again, either there was an attendant that was not paying attention or whether something happened during the process of the showering. When I analyze those type of cases, and we will analyze the case from either side, we will analyze what is the degree of the injury. How deep is the patient burned? Is that consistent with the history as given? For instance, if you have a situation in which they tell you that the patient was only exposed to the shower, let's say, for 10 seconds, and that the temperature of the shower was only, let's say, 100 degrees, then you could not have a third-degree burn. It's impossible to have that type of burn with that type of history. On the other hand, if you have a water that is, let's say, 155 degrees, and the story tells you that the patient was exposed to that for 20 minutes, but when you evaluate the claim, the patient only has first-degree burns, then it is also impossible, because with that type of exposure and that degree of temperature, you would have a patient with true third-degree burns, which are the deeper type of burns. So that is the reason why these type of charts are very useful. They're very graphic, and they come very, very handy in dealing with the litigation aspect. Okay, let's go to the next topic, which is the second topic that is very common. The number one was related to hot showers, to hot tubs. The number two that I see all the time is related, of course, food and beverages related scalds, McDonald's, Starbucks, Chinese restaurants, those type of claims. Cooking related scalds, mostly related to people that have either a catering truck or people that work in the kitchen, those type of claims. And of course, again, temperature and duration of exposure becomes, again, very, very important. We'll go to this. This is the same, basically, chart, but I just wanted to call your attention at something. I hope that you can see it in your screen. If you look at the chart, it says there that between 160 and 180 degrees is the temperature of freshly prepared coffee, hot chocolate, or tea. And you see there that at those temperatures, you could have a burn in 1.5 seconds. Now, for all of you that that deal with this type of situation, the brewing temperature of coffee is much higher than 180. The coffee is contained in the recipients between 160 and 180, but the brewing temperature is higher. So this is an area that is actively being litigated by both sides in this field. But for all of you that deal with this type of injuries, I wanted to tell you that this is an area that is particularly hotly contested. Excuse me the pun, hotly contested in the sense that there's literature back and forth as to what is the appropriate or should be the appropriate setting for these hot beverages to be kept at, and what is what the consumer prefers. So that is kind of a side effect. Thank you very much for that question. There's a question, somebody wanted to know how hot was the coffee in the McDonald's case that made the news headline years ago. The answer is I do not know. I can just tell you that I was involved in a different McDonald's case just recently, and that at that particular case, the case, most of the allegations in the case had to do with what was the consumer preference with hot beverages and what was the appropriate temperature in which coffee should be held. So that was the area that was very hotly contested. I believe that in the McDonald's case that made headlines, there were some other elements that were in place. Not only was related to the temperature of the coffee, but I believe that it was related as to the safety of the container itself. Again, I'm not privy to all the details, but I think that there was more than just the temperature of the coffee, because I think that nowadays that in itself is not really what makes the case. So we make it interested. There's another question concerning food burns. The food burns are very common. I can tell you that I've been involved in many, many cases, some of them quite interesting. For all of you that are skiers, there are a number of products that are supposed to keep your foot warm in the boot, and I've had a couple of cases in which plaintiffs have burned themselves with those products. So that's an area of particular concern. I got to tell you a few of other cases that are related to hot steam burns. Patients that attend hot steams may sustain foot burns. Also because many of the population in the state, many people are diabetics. Diabetics suffers from peripheral neuropathy, meaning that they do not have normal feeling in their extremities, particularly on their feet. So if there is any medical background that will decrease the sensibility, it will increase the susceptibility of these patients sustaining burns. Burns occur when patients, for instance, do not wear shoes, and they may walk in areas that are hot, but because of the peripheral neuropathy, do not feel the burn. Burns may occur also in different types of settings when somebody is unfortunately having a pedicure. As we all know, nowadays they would put your feet into hot water. Hopefully the water should not be hot, but again, if you're dealing with a patient that is either diabetic or a patient that is on steroid medication, which produces thinning of the skin, you could have an injury that would not normally occur in another patient. So these are very, very common type of injuries, and because they sustain the burns in the feet, is an area that is difficult to treat and difficult to heal. So they commonly do need to be skin grafted, and then they need a period of physical therapy. They need to wear pressure garments, special shoes. So they are complicated injuries. So what I would say from either the defense or the plaintiff point of view is that there are a particular subsection of burn injuries, and that as such, it requires special attention. There's also another question, which is a very interesting question: laser burns, very, very common. It happens. I can't even tell you how many times. The reason why it happens is because laser is basically concentrated light, and basically is a burn. So basically, when you have a laser that is being, as you know, when you apply the laser, we're able to calibrate the settings, the intensity, the number of applications, the number of passages, and the type of laser that is being used. The particular type of skin has to be assessed. The particular type of sensitivity, there's a test that is being given before the laser is being applied. So laser burns are very common because many people do not realize the injury that is being occurred, and it's very common standard of practice that the laser is being applied by either a technician or a nurse practitioner or a nurse under quote-unquote a doctor's supervision. But in many of those cases, there's either no supervision, poor supervision, or the guidelines for the application of the laser are not what they should be. Even if all of those parameters are met, many times the laser is applied too intensely, too many times, and laser burns is one of the most common complaints and claims that I see that I have to either defend or pursue depending upon what case I'm working with. So this is not an unusual occurrence. Yes, some types of skin types are more prone to laser burns than others, and what is even more importantly, after they are burned, some types of skin are more prone to scar. In plastic surgery in general and in the burn field in general, we know that as a general principle, the lighter the skin, the better the scarring. Meaning that people that are of white Caucasians and that have really white skin will, in most cases, have a very nice and fine scar. And as you go, the gradient of olive skin and darker skin and oriental skin and Latino skin, then the scarring becomes progressively worse with increasing hypertrophy, which is basically thickening of the scars, and with increasing keloiding. So it is, in reality, it is a problem. When you're dealing with darker skin, it is always a problem. So those are type of the lasers are very common. We see that all the time, and certainly is a situation that we deal with all the time. There's another question related to whether some areas of the body do heal faster than others. The answer is yes. The thicker the skin, the quicker you're going to have healing. And without trying to be funny about it, I just want to tell you that one of the areas that heals the best is the scrotum, because the skin is so thick and convoluted that it rarely is in need of a skin graft when that area is burned. And the areas that are thin, of course, have problems healing, because just for everybody to understand, and I wanted to talk about this later on, but I think this is the appropriate time. We have to think about the skin like a 10-story building. Imagine a 10-story building, that is your skin. So when you have, for instance, a first-degree burn, the upper 2 or 3 stories of the building are burned. When you have a second-degree burn, the next 3 to 7 stories of the building are burned. And when you have a third-degree burn, the building is being burned to the ground. So if you imagine the layers of the skin as being stories of a building, then that is the degree of the burn. The deeper the burn, third degree and fourth degree, the more of the stories have been burned. And certainly some of the stories are taller than others. So for instance, the palm of your hand, the sole of your feet are very thick skin. The back is very thick. So all of those areas, when they get burned, they normally heal without any problems. On the contrary, for instance, the eyelids, the back of your hand, the inside of your arm, those are areas in which your skin is normally thin. So in those areas we have more difficulties with healing. We normally may have to skin graft because, again, the height of the building is not so high, and consequently those areas do get burned. Let's see. Okay, this is an interesting question as to, they wanted to know, this is a question in which a girl sustained a burn when a heat pack exploded. I imagine that was the type of heat pack. Let's see. The content inside melted and burned into her skin, causing permanent scar. And the question that is posed to me is, what type of chemical is usually found inside those heat packs? The answer is I do not know. But certainly that would be a case of a chemical injury. That would be compounding the heat that was produced by the heat pack. Certainly whatever was inside was a chemical that produced the injury. And we can basically touch upon the difference between, many people think that the worst burn are the acid burns, but in reality the worst burns are related to alkali burn. So the higher the pH, the more alkali the burn, the worse the burn. The reason for that is because an alkali burn will burrow more deeply into the skin than an acid burn. An acid burn, even though everybody thinks, oh my goodness, it's acid, the reality is that it would tend to stay much more superficial than an alkali burn. So burns, for instance, due to lye and to alkali type of elements are much more serious, much more extensive, and we are much more concerned about those type of burns. So each time that you see an alkali burn, you should be very concerned about that. There's a follow-up question with the laser. Yes, there is the question is whether they do test spotting. Yes, there is a protocol to do before applying. They should test spot before you apply any type of laser. Okay, let me see. The skin of the face is usually, well, it depends. The question is, how thick is the skin on the face? Certainly it depends whether it's a male or a female. But the normal skin of the face of a male in the area of the beard is quite thick, meaning that that's an area in which you rarely would have an injury that is too bad. Of course, if you have a very severe burn, that's another story. But the area of the male beard is quite thick. If it is a female, I would say that the thickness of the face we consider to be medium, with the exception, of course, of the eyelids that are very thin. The nose, some people have very thick skin, and in general is considered to be medium. So most of the face we would consider to be medium, with the eyelids being thin and the male beard be thick. So that's the answer to that. How does the age of the burn victim affect the healing and scarring? Very interesting question. The older you are, the better the healing. It works inversely. The reason for that is because when you're young, your scars are young and powerful, and they will tend to heal the burn very aggressively. So the younger the age of the patient, the worse the scarring. The scar will be much more exuberant, much more thickened, and it will be, from a functional point of view, is better in the sense that the scar is harder and thicker, but from the cosmetic point of view, of course, is the opposite. An older patient will have a very fine scar that you could hardly see, but the scar will be not as strong, but certainly from what we consider aesthetically, it will be better. So that's the answer to that. We're going to keep ongoing with this. I really appreciate the questions. I see that many of you have to deal with these issues, and I imagine that's the reason why you're here. But let me go forward, because I wanted to talk to you also about a few other points. Okay, I wanted to tell you about, this is the chart that you see there is the chart that I most often present when I'm being either deposed or when I go to court. The reason for that is because it's a nice color chart that tells you that the severity of the burn, of course, as you go to the top, you see the bright red, the pink in between, and the light pink at the bottom. But again, I just want you to leave, if you can, just with this. At 120, you can have a burn in 5 minutes, and at 155, you can have a burn in 1 second. So this occurs very quickly. And again, this is very, very important for us when we analyze the story of the burn, the pattern of the burn, and as to whether what the patient is telling us is really indeed what happened and could have happened or not, according to the story that they tell us. And you can see that again why this would be important. Okay, let's go to, I want to talk a little bit about something that is interesting, which is electrical burn, chemical burns, contact burns, and frostbite. Just to touch briefly about frostbite. A frostbite is a burn. It's treated like a burn, is treated at a burn center. The mechanism of the injury, of course, is not heat, but it's cold, but it's basically the same type of deal. Nowadays, there are a bunch of cases that are related to what is called cold therapy. For all of you that deal with orthopedic cases, orthopedic surgeons nowadays, and for a few years now, they've been very, very happy about utilizing cold therapy units after surgery in order to decrease the swelling and the pain. And a number of allegations have been made as to what is the appropriate use of these cold therapy units, whether they are too cold, whether the instructions are appropriate, and whether or not there are injuries that are related to these machines. So again, this is a type of a case that is very interesting. It's a frostbite. Is a contact burn because, of course, it occurs by the cold unit being in contact with the skin, and it opens an entire new area of litigation. Contact burns, they occur, of course, when the patient touches something. We see that very commonly in cases of abuse. Somebody's been burned by a hot iron, or somebody is being pressed against a fryer pan, or somebody is being pressed against a heater. So those are burns that we see quite often, and of course, the pattern of the burn tells us a great deal, as well as the depth of the burn. If the pattern of the burn, of course, is the same as the offending agent, so then, of course, you have an open and closed case. But most of the time, that is not the case, and we have to analyze the same way that in an immersion burn, whether there are lines that are clearly demarcated that would be consistent with pressuring against the offending agent, and whether the burn is uniform. The fact that you have a uniform burn is very meaningful. The chemical burns we touch basically between acid and alkali, and I want to touch a little bit upon electrical burns. Electrical burns are major burns because there are basically two types of electrical burns when we talk about electrical burns. There's the flash burn, which is basically just a heat burn. It's basically like a flame burn. And then there's the direct electrical burn, in which the electricity will go through the body of the patient. Those are, of course, the most damaging type of burns because the flash burn is just an injury to your skin. But the direct burn, because the current goes through your body, there's damage through your muscles, through your nerves, through your bones, and through your vessels. And what is the most important thing is that the damage continues after the injury has subsided. The reason for that is because the vessels are damaged, and the damage is a progressive damage that will slowly but surely occlude the blood supply, and that the areas that are irrigated by those vessels will slowly die off. Consequently, a direct electrical burn that has an entrance point and an exit point, and of course, most often than not, the exit point is the worst area of injury. Not only is greater in size, but is deeper. Those are areas that are very important to analyze, and many of these patients end up with amputations, if not dying, and many of these patients suffer from tremendous cognitive issues. So cognitive issues and electrical injuries go together besides the burn injury per se. So that is basically just a consideration of this type of burns. Okay. Let's go to the other type of burns that we see, and I want to touch a little bit upon what is the difference between first, second, and third, and what is what we call, why doctors call it a partial thickness, and what is a superficial, and what is a deep partial thickness burn. A first-degree burn is basically a sunburn. Normally, it heals without any scarring, unless, of course, you can have a deep sunburn, or what is common now, and I hope that none of you are attending those, is tanning booths and tanning salons. Tanning, which is very popular, is basically a burn. The UV lighting that is used, the UV radiation, they use UVA and B, does produce a sunburn. Some of these produce a burn that is deeper than a first-degree burn, even though you do not see it, and some of them can lead to scarring. But a basic sunburn, which is a basic first-degree burn, should not leave you to that. There's a very interesting question: is a third-degree burn more or less painful than a second-degree burn? Okay, I'll answer that because that's a very good question. A second-degree burn goes a little bit deeper and is typically seen as a blister. So when you see a picture or you see a patient with a blister, the diagnosis immediately is second-degree burn. First-degree burn do not blister. Third-degree burn do not blister. You only have a blister when the burn is in between the stories of the building. The story number 4, 5, 6, then the wound will blister. Now, what is the difference between a superficial and a deep partial thickness burn? Partial thickness means that a portion of the skin has been burned, but not the entire skin. A superficial means that only the upper stories of that building have been burned. A superficial second-degree burn is typically a blistered burn. A blister is basically a superficial second-degree burn. A deep second-degree burn or a deep partial thickness burn typically has no blistering. What you see is red, is a red surface, moist. There's liquid that is seeping through. It is usually painful, but is red, is angry. That is a deep second-degree burn. A full thickness burn means all the layers of the skin are burned and is your traditional third-degree burn. One of the ways that doctors make a diagnosis, because sometimes we cannot initially make a diagnosis, between a second and a third-degree burn is by using a fine needle. We would press the needle into the burn. If the patient does not feel the needle, it's a third-degree burn. Typically, a third-degree burn is painless, meaning that not only the skin has been burned, but the nerve endings have been burned, and traditionally a third-degree burn is described as painless. So if you have a patient that complains of pain, then he has a second-degree burn. Now, that is not to say that a second-degree burn that initially was painful may not progress to a third-degree burn that is now painless. And the reason for that to happen is because there is an initial period of about 48 to 72 hours, which is the initial period that it takes for a burn to what we call declare itself. That period in which a burn will declare itself takes 48 to 72 hours and is related to the time that it takes for a burn to manifest fully, for us to tell for sure what type of a burn it will be. And that is particularly true with electrical burns, with chemical burns, and with high-intensity flame burns. We do not know at the beginning what a burn will ultimately become, and were the burn to become infected, the infection per se may deepen the degree of the burn. So you could have a burn that is initially and for the first week a second-degree burn, but if that burn is allowed to become infected, is untreated, and it goes on to become infected, it may turn out to go to a third-degree burn, meaning that all the layers of the skin are now dead. So that is one of the reasons why initial treatment is important, and that is one of the reasons why antibiotics are given at any sign of infection. All right, let's go to flash versus flame burns. Very common for all of you that have dealt with apartment fires and all the litigation that goes around that. Also, car fires are very common, rollover car fires, and of course the ever so ubiquitous propane explosions. Barbecues, very common type of injuries. And in all of these type of injuries, there's certainly an element of smoke inhalation. Smoke inhalation basically means an injury to your lungs. If it is severe, the patient has to be intubated, put on a ventilator, and may make the situation worse by because it's another source of possible infection, possible demise of the patient if the situation is serious. But certainly smoke inhalation is something that we see and is something that can produce a chronic effect. So as such, we have to be careful with that. Flash versus flame. A flame is usually a much more severe burn. It's usually a deeper burn, means the patient was exposed again to the two elements that we've spoken before, intensity of the temperature of the burn and duration of exposure. Usually patients are exposed to the flame for longer periods of time, and the flame is usually of a higher intensity. Flash burns are usually not as deep, but that is usually. Sometimes, of course, that can change. Okay, let's go to the next. I wanted to basically talk about treatment. I'll do it very quickly. I know we're running out of time, and I appreciate everybody's patience. That is a question. Whoever asked the question as to the life expectancy, that is a question that is asked in every case that I've been involved of any severity. And this is the answer to it. The answer is that in general, we're talking in general, life expectancy is not reduced by a burn. That is my general answer. But again, the answers is not a black and white situation. It depends upon who the patient is, what is the situation of the patient before the injury, and what other concomitant injury have occurred. Sometimes, not sometimes, but many times, these burn injuries are accompanied by other traumatic events, fractures, internal injuries, neurological injuries, other type of injuries that make the situation much worse, and we have to analyze it from that point of view. But in general, we cannot say that a burn per se will reduce your life expectancy. The answer is no. Okay. Okay, let me see what else we have here. Okay, I want to just basically a treatment overview, and I know that we're about to finish, but basically the acute phase is the resuscitation, dressing changes, and very important, pain control. Pain control and burns is an issue that always comes up in those areas in which pain and suffering is an issue, and in many of the cases pain and suffering becomes an issue, particularly in patients that go not only through the process of being treated at a burn center, but people that ultimately do not survive the burn center stay. So there's always an issue as to what was the pain and suffering that was that the patient was exposed to, and many of the arguments that go back and forth are related to what was the level of comfort of the patient. And I've been involved in many such a case in which that was one of the main elements of discussion. Skin grafting nowadays, there's very few places, I would tend to believe that in the United States probably none, in which pig skin is being used as a temporary skin substitute. Nowadays we have some other types of skin substitutes. Most of the burn units still use cadaver skin as a temporary substitute. When I mean by cadaver skin, I mean skin from dead people that is harvested and is used as a temporary skin substitute. And then once that is removed, autografting, meaning that skin grafting from the own patient has to occur. Physical and occupational therapy is of utmost importance, and psychological and psychiatric intervention again is part and parcel of a large burn injury. These patients suffer not only the physical but also the psychological trauma that is related to this. Rehabilitation is done in cases that are serious burn injuries. And I'm going to touch briefly on the last subject before we have to leave. Pressure garments, silicone inserts, and face masks. Face masks are custom-made. They're worn by the patient for about 2 years following the injury. They're made of a material that is called UVEX. It's a plastic material. Pressure garments are custom-made garments that are supposed to keep, like the name implies, a lot of pressure. Sometimes we use silicone underneath the pressure garments to put more pressure. And one comment that I want to make to both sides, to the plaintiffs and the defendants. Burns change, meaning that there's a lot of scar remodeling. What you see is not what you're going to see at the end of the scar remodeling. And we say in the burn community, it takes about 2 to 3 years till the burn will obtain the final appearance. So it would take 2 to 3 years till you can really evaluate what the burn scar will look like. And nowadays, the many modalities of treatment, surgical and otherwise, that are used to take care of these scars. So when I would do an evaluation of a patient, we would put there what is the future medical, what is the patient, what are we able to do with this patient, and of course what would be the costs that are associated with the reconstruction, but they are brand new techniques of plastic surgical reconstruction that are quite useful in these cases. And one last consideration. Many of these patients are treated in burn centers that are not associated with plastic surgical rehabilitation consultants. It is important for your patients, either from the defense of the plaintiff, to be evaluated by a plastic surgeon that is experienced in burns so they can tell you a look into what's ahead of the patient and what is possible for the patient. Matt, are we about finished, or is there anything else that...
We are. If you have time to stay on the line, I think we have 3 questions.
Go ahead.
If you have time and would like to answer them, I sent them to you. You can answer them.
Okay. How do you assess pain in a heavily sedated patient? Excellent question. The question becomes more complicated because if a patient is heavily sedated, it depends whether the patient is being on a ventilator or not. Because what happens, if the patient is on a ventilator, he's usually paralyzed as well. Not only medications are given to the patient for him not to have pain, but medications are given for the patient for him not to be able to move. Consequently, the patient may or may not be suffering from pain, but you wouldn't know because the patient is not able to move. It's like those nightmare movies of a patient being under an anesthetic, suffering pain from the surgery and being unable to move. Is the same situation. And I've been involved in cases in which we were alleging that the patient was still suffering of pain because not the appropriate amount of pain medication was not being given since the patient was paralyzed and the nurse was not able to assess the pain. But let's say the situation is not that, and let's say that the patient is just sedated without being paralyzed at the same time. The only way we assess that is burns, the dressings need to be changed constantly. So when the nurse or the technician will go ahead and change the dressing, then the patient will complain of pain. If the patient does not complain of pain, or if the pain is mild, then the patient is appropriately sedated. So pain is something that accompanies the burn patient in the burn center environment all the time. Debridement. Debridement, of course, has to be done with all these burns, because if we don't do the debridement, which is basically the excision of the tissue, they will become infected, and infection may lead to blood poisoning, septicemia, and eventual demise. So the debridement, we usually do it with the patient under general anesthesia. So basically what we do, we take the patient to surgery, cut away the dead skin with a knife, and then usually put a cadaver skin. That is the first stage. And then we take the patient back to surgery, remove the cadaver skin, and take skin from the patient and do the autografting. The question is, if a third-degree burn is painless, what pain is being controlled during the acute phase of a third-degree burn? Good question. It depends how big is the third-degree burn. If the third-degree burn is only a small area, then you do not need pain medication because there is no pain. But what happens is the following. The patient is taken to surgery. The third-degree burn is cut away, and what you now have is raw subcutaneous tissue that has plenty of filling. And you have to do dressing changes. So when the patient had the covering of the third-degree burn, he had no pain. But once you remove that third-degree burn and you start the treatment modality, then it's painful, it's plenty painful. So we still have to give him a lot of pain medication, and that would still be considered the acute phase. How do you assess the potential for long-term care if a client is currently treating? You do, because these burns, even though they're catastrophic burn injuries, they all more or less fit in a pattern. After you've seen a number of cases like I have, and like experienced burn surgeons and plastic surgeons have, they all kind of fit a pattern with little variation, but you're able to assess the future needs, the future medical and surgical needs, and the future rehabilitation needs, and the future for potential gainful employment later on. So I think that is easy to do for somebody that is used to deal with this type of evaluations. Thank you. I appreciate everybody's. Matt, are we finished?
Yeah, Dr. Brones, I'm just going to wrap things up here by thanking everybody for attending, but especially thanking you for taking time out of your busy schedule to impart some of your wisdom to us. It was a great presentation, and it showed that you put a lot of time and effort. So we on behalf of everybody who attended, thank you. We've gotten a lot of plaudits for your presentation.
Thank you. I appreciate that. I hope that everybody got something out of it.
Yeah. And if you have a case that you would like to speak to Dr. Brones about, you can contact us here at TASA. Our phone number is up on the screen. It's 800-523-2319. We will be sending out a link to the archive recording of this webinar later on this afternoon. We'll also include Dr. Brones' PowerPoint presentations, which have some of those great charts in them. And the archive recording, like all of our archive recordings, are posted in the Knowledge Center of TASA's website. Our next client-focused webinar will deal with school transportation issues. It will take place on May 13th at 2 p.m. Eastern Time. And if you have any follow-up questions or comments, if you have any suggestions on how we can improve these webinars, please feel free to send me an email. My email is mhyde@tasanet.com. Thank you again, Dr. Brones, for your time.
You're quite welcome.
To all the attendees that took their time out of their busy schedule. I'm now going to end the meeting, and you should receive an email from me later on today. Thank you.